Good afternoon, everybody. Happy lunchtime. Hopefully everybody's taking a little bit of a break, getting their lunch and settling in for this ECHO session. We have a jam-packed session. So we got a presentation from Dr. Zach Hansen. We'll go with him first, and then we will switch over to a case discussion from Dr. Hillary Wonder Genius. So we will throw it over to her. We'll show the case and walk through it and get some discussion. But for those who have just joined, please use the chat to introduce yourself and also for CE credit. So we're looking for your name, your email, your organization, and your credentials, and we'll track those accordingly. If there are any tech issues or anything like that, please feel free to message myself, or you can message Elizabeth Minnick, who is also labeled Project ECHO. So if you have any tech issues, just let us know. If there are any questions or comments, anything like that, you feel free to put them in the chat. Use the raised hand feature or unmute, and we will try to keep track of those who unmute. Although I will say with 31 people now, it will be hard to keep track of the Hollywood squares. So just keep that in mind. So it's always best to use the raise hand feature because that alerts us. But after that, I think we can go ahead and get started. Let me pull up your slides, Dr. Hansen, and then we'll get things going.
Hello, everybody. So I've been dealing with laryngitis, so I will do my very best to speak clearly, although I'm better today than what it was over the weekend. So I'm going to primarily try to talk through sort of cannabis use disorder, sort of in general, but then also have a few slides that are more specific for the pregnant and postpartum population. Next slide, please. So cannabis, third most commonly abused psychoactive substance worldwide after alcohol and tobacco. Obviously, it's prevalent. It's going to only become more prevalent as legalization takes place, both from for medical purposes and also recreational. So when we're talking about cannabis, we're primarily talking about the delta-9 tetrahydrocannabinol, or THC, which is the psychoactive property that has the effect that everybody sort of utilizes for various reasons. Multiple delivery systems, smoking, vaping, dabbing, which is a wax-like substance, ingesting edibles, beverages, tinctures, and then topical creams. Cannabis use disorder develops in about 10% of regular cannabis users and up to about 50% of chronic daily users, associated with some cognitive impairment, poor school and work performance, and then some psychiatric comorbidities, and we'll dig more into that here in later slides. Next slide, please. So what are the sort of acute intoxications or acute effects? Tachycardia, or increased heart rate, blood pressure changes, conjunctival injection, sort of the red eyes, dry mouth, slowed or slurred speech, ataxia, difficulty sort of with walking, increased appetite, the typical munchies, the euphoria or high, relaxation, sedation, impaired concentration, poor attention, sort of episodic memory, and then impaired learning. Next slide, please. So those are sort of the acute symptoms. So what are the more sort of persistent symptoms that you see with chronic use? Most studies will show that it is dose dependent. So it depends on how much they're using and the concentration that they're using. But usually those symptoms or persistent symptoms can resolve after 3 to 30 days. So some chronic mood changes, persistent depressive disorder or major depressive disorder has been associated with new onset mania, exacerbation of mania with bipolar, but there's unclear association with anxiety or trauma-related disorders. Definite impairment in school and work function, giving up previously enjoyed social and recreational activities. And we'll see this as we look through the criteria for cannabis use disorder, and then some persistent or recurrent interpersonal problems. There is an increased risk for psychosis, and then has been linked to development of schizophrenia, especially if utilized or using cannabis during early adolescence. Next slide, please. So what are sort of the predictive factors? So early age of first use is early or rapid progression of frequent use, and so concurrent use of other psychoactive substances such as alcohol or tobacco. And these are all predictive factors for what the increased likelihood of developing a cannabis use disorder. Some comorbid psychiatric disorders, both depression, anxiety, stressful life events, so ACEs, which I'm sure we've talked about before in other presentations, peer use of drugs, and then social isolation. This was interesting. They saw a significant increase in use in California during COVID-19, and therefore sort of being isolated increases the use of cannabis. Next slide, please. So to screen or not to screen, the USPSTF recommends screening all adults for harmful use of psychoactive drugs, as long as you can make an accurate diagnosis and there's effective treatment, appropriate care can be offered. And so, we should be asking about cannabis use along with alcohol, tobacco, and other illicit substances. Sort of how do you do this? There are brief questionnaires that have been validated, but really single question in the past year: how often have you used marijuana? And the key is more than once. So if someone used once, unlikely to be problematic use. If they've used more than once, then they need further screening to determine of the significance of their use. Drug testing, typical for safety sensitive workplaces or high risk populations. Typically THC or its metabolites can be found up to 6 weeks in urine, also in oral, hair, blood is possible. And then assessment, which we'll talk about on the next slide, for any positive screens to sort of evaluate their risk, and then a brief intervention if necessary, referral to treatment if at higher risk for comorbidities. Next slide, please. So what's included in the assessment? So cannabis use, including amount, frequency, and route. There are attempts to cut back or stop cannabis use, and we'll see this is one of the criteria for cannabis use disorder, is having an effects on their occupational, academic, or social functioning, use in high-risk situations, like driving, operating machinery, mental status exam, psychiatric history. Again, these are predictive factors for a problem, social history, medical history, family history, and then are they using any other substances? And we'll see a strong association with other substance use disorders in later slides. Next slide. So kind of busy, not going to necessarily read through all of these. If you're familiar with the DSM-5 criteria for any substance use disorder, straight down the line, taking more persistent efforts to cut that back, using a lot of time, the cravings, withdrawal, tolerance, etc. So the same criteria that we use for other use disorders. And then next slide. And then obviously the same clarifications: early remission versus sustained remission, and then mild, moderate, or severe. So 2 to 3 symptoms for mild, 4 to 5 for moderate, more than 6 for severe. So next slide. So some statistics sort of more prevalent or more pertaining to sort of this population. So one of the most commonly used substances during pregnancy, typically it varies according to maternal age, racial or ethnic background, and socioeconomic status. So self-report use is 2 to 7% in many studies, but there was one study showing up to 30% usage in young, urban, socioeconomically disadvantaged individuals. Among individuals self-reporting use, about 18% met DSM-4 criteria for use or abuse or dependence. Rates of use are increasing, and so it's become, as legalization has taken place, and the rates of use are increasing. So increased from 3 to 7% from the 2001 to 17 timeframe. During that same timeframe, the rates of alcohol and tobacco have dropped. So we're doing better in some in some areas and worse in others. And then the perceived lack of risk with legalization. So the percentage of females who believe regular marijuana is at no risk during pregnancy increased from 4.6% to 19% from 2005 to 2015. I couldn't find any more up-to-date statistics, but I'm going to assume that it's probably in the 20s to 30% at this point. Again, with sort of the legalization process and a lot of the information that's out there related to its perceived benefits. And so looking at family and twin studies, there is a substantial heritability for initiation of cannabis use and also development of cannabis use disorder, although they haven't been able to identify any single gene or polymorphism at this point. Next slide. Can you come back? I'm doing a talk. Come in. Sorry, I'm doing a talk. Okay, I'll get it when I'm done. Thanks. Sorry about that. Probably should put a sign up. So looking at other comorbid conditions. So alcohol, adults with alcohol use disorder are 6 times more likely to have cannabis use disorder. And then vice versa, those with cannabis use disorder are 3 to 4 times more likely to have alcohol use disorder. Co-occurring use leads to more intense intoxication, so is problematic with using both. Tobacco, again, 6 times more likely to have CUD, 3 times more likely to have tobacco use. So co-use decreases likelihood of being able to abstain from either substance. From opiates, obviously those individuals with opiate use disorder are more likely to have cannabis use disorder. So about 23% is sort of the average, but the range is 12 to 67%. I feel like 23% is probably relatively low for our practice, but maybe I'm not, maybe not, I don't know, but it seems like it's more. And then those with cannabis use disorder are 5 times more likely to have opiate use disorder. Stimulants, again, association between the two. Adults with CUD are more likely to have a cocaine use disorder or prescription stimulant use disorder. It's also some association with sedative hypnotics medication, so whether that be sleep aids or benzodiazepines, also associated with hallucinogens, and then inhalant solvent use. And so obviously a lot of people sort of debate sort of the gateway theory related to marijuana use disorder. Seems to be pretty closely associated to me, or some sort of link to use disorders with cannabis use, but often debated sort of in the within the medical profession and also in the non-medical professionals. So depressive mood, anxiety, abnormal negative mood regulation, persistent conduct disorders, child or adolescents, parental cannabis use, adverse childhood experience, stressful life events, all sort of predictive factors, as we sort of mentioned before, but just sort of driving home that point that these are things that need to raise the likelihood of that we screen and sort of assess. So next slide, please. So comorbid conditions from a psychiatric standpoint. Depression, individuals with depression are twice as likely to have cannabis in the last month. Heavy cannabis use were more likely to have a major depressive disorder. So definitely some cross effect. Bipolar, lifetime prevalence of cannabis use was 24% in those diagnosed with bipolar. 3 times the risk for more new onset of manic symptoms, and also earlier age at onset of first manic symptoms. I thought this was interesting. We typically think of cannabis and THC as sort of a relaxing effect, but yet these studies have shown that it actually is increasing the likelihood of manic episodes, which would be opposite of what one would expect. So 4 times the odds of bipolar 1 diagnosis and 3 times the odds of bipolar 2 diagnosis compared to those that don't have a cannabis use disorder. Schizophrenia and non-affective psychosis, 2 to 3 times more likely to have a cannabis use disorder. Anxiety, 2 to 3 times more likely, again, to have cannabis use disorder. Post-traumatic stress disorder, 10% prevalence for cannabis use disorder or current cannabis use. There was one study looking at veterans and found up to 75% co-occurring of PTSD and cannabis use disorder. And then ADHD, 10 to 30% prevalence of cannabis use disorder among adults with ADHD. And we have found that there's a connection between untreated childhood or adolescent ADHD, which is a risk factor for developing a cannabis use disorder later in life. So next slide, please. So what are some of the medical or systemic effects of cannabis? So from a pulmonary standpoint, increased cough, sputum production, wheezing, dyspnea. No direct association with cancer from lung, head, neck, or oral, but there is increased risk of one particular type of testicular cancer, the non-seminoma. Cardiovascular, increased risk of MI post use of cannabis, increased risk of stroke post use, and then there is a slightly increased risk of cardiac arrhythmias post use. Reproduction does not seem to have an effect on sexual function in of itself, but does reduce spermatogenesis and sperm function. So there is some link to infertility, although has not been repeatedly shown in studies. Neurological short and long-term effects on cognition, including attention, concentration, memory, learning. If you look at sort of the brain itself, reduced hippocampal volume and gray matter density, thinning orbital frontal cortex, and smaller cerebral white matter volume. So I'm a long time removed from neurology, but seems bad that it's having definitive effects on the brain. But there's no known associated effects with the hepatic, renal, endocrine, or ophthalmological system. Next slide, please. So pharmakinetics. So chemical product from marijuana does cross the placenta, and it is excreted in breast milk. Ultrasounds showing their increased vascular resistance in daily users, which can lead to impaired growth. And we'll talk a little bit more about that in a future slide. So contemporary marijuana products have higher concentrations of THC than previous decades. And so I found this slide, sort of looking through, and you can sort of see the pink line is the percent THC. And so you look back in 95 and you're looking at roughly 4% THC, and then moving into 2019, 14 to 15% THC. And so, we say this is not the THC of Woodstock, and it absolutely is not. This is 95, to go back another 20 years, I'm sure there's significant difference. And you can also sort of see that the CBD concentration, which is the blue line, has gone down over time as well. So a lot of individuals, will ask about CBD and whether it's safe. Sort of my standard answer is that there is no purification process or FDA regulation of CBD products. And there was a study that was done a few years ago looking at CBD products, and a majority of them, did not have the concentration of CBD in the product was not accurate, and B, a majority of them actually had some level of THC in them as well. And so if someone comes in and says that the CBD is working great, the question is it CBD or is it the THC that's giving them the effect that they feel is showing efficacy or helping them? And then some boutique growers now are producing concentrations up to 30%. And so with legalization, the concentrations that patients will be getting their hands on is fairly significant and very problematic, in my opinion, related to some of the significant side effects that particularly psychosis and other sort of psychiatric side effects that patients may have. So next slide, please. So looking at social outcomes. So a lot of the literature before 2016 was really either inconclusive or said that there was no increase in low birth weight or preterm births. The population studies since 2016 have really contradicted this. But a lot of them have been retrospective studies and have been dependent on self-reported cannabis use, which is not the most solid of evidence, but it seems to be growing at this point. So, sort of mentioned 3 specific studies. So 32,000 individuals comparing non-users to self-reported use, increased risk of low birth weight, small for gestational age, There did appear to be a pretty significant dose effect done. And the dose effect was weekly use was defined as heavy use, which is a pretty low bar for defining heavy use. I would assume most patients are probably using daily versus weekly. Second study, sort of 9,000 prenatal cannabis versus non-users. So twice the rate of preterm births, 12 versus 6%. Greater frequency of small for gestational age, which is defined as less than the third percentile, increased placental abruption, increased risk of transfer to the NICU, and lower APGARs at 5 minutes of less than 4. And then another retrospective study, close to 5 million U.S. mothers. Maternal cannabis use was associated again with small for gestational age, preterm birth, low birth weight, and death within 1 year, which is scary. If we're going to look at cannabis use as a social determinant to risk stratify these infants. Next slide. So talking a little bit more about that. So the Stillbirth Collaborative Research Network, marijuana use was associated with a 3-fold increased risk of composite neonatal morbidity and death. So again, it predicts bad outcomes, for these infants. 500,000 pregnant Canadian women reporting cannabis use, about a 50% increased risk for autism spectrum disorder diagnosis. And then several studies have reported impaired neurodevelopmental outcomes, particularly in attention, visual, spatial functioning, hyperactivity, problem solving. And then a lot of these studies were relatively older, since we're kind of limited in our ability to study it with it as a class 1 sort of controlled substance. And so a lot of this is older research showing effect on these infants and children. And there is no link to congenital anomalies. So up to this point, at least. So next slide. So what's the advisory? Don't do it. ACOG, AAP, American Academy of Breastfeeding Medicine all say don't do it. So, I mean, simple take home. I don't think anybody was necessarily expecting me to say that it was fine, but everyone agrees that we need to stay away from it. So next slide, please. So a topic that sometimes is debated, is there a defined cannabis withdrawal? Definitely appears to be. So sleeplessness, about 14%, irritability, 14%, anxiety, 13%, depressed, 11%, headache, 12%. So, when you add them all together, most individuals will have some symptoms of withdrawal. So not probably less than 10% restlessness, decreased appetite or weight loss, abdominal pain, shaking or tremor, sweating, fever or chills also can be associated with withdrawal. So typically appear 24 to 72 hours after cessation of use, usually peak around the first week and resolve 1 to 2 weeks after, although the sleep-related issues tend to linger. Withdrawal symptoms can be disabling and can inhibit attempts to cut down or abstain. The primary risk factor, obviously, is the frequency of use and the concentration of the product. Women tend to experience more mood and GI symptoms versus men that tend to have more sleep-related issues. And then PET studies have shown that chronic daily smokers have a 10 to 15% downregulation of the CB1 receptor. And so they hypothesize that this is probably where a lot of the withdrawal symptoms are probably related to this receptor. Next slide, please. So talking just a little bit about treatment. So the treatment goal typically is broken down into one of two things, either complete abstinence or harm reduction or sort of decrease in cannabis use. Reducing frequency is associated with a greater improvement than the reducing the quantity of use. Most young adults do set goals of harm reduction, which is, I found very interesting. Not many other use disorders are we going to say just cut back is okay. I mean, everything else we're going to say that abstinence is best. So first line consideration typically is therapy. There's no FDA approved medications at this point, although there is some evidence of withdrawal management and support and abstinence with some different medications, and we'll run through those quickly here in a minute. Next slide. So from a therapy standpoint, motivational enhancement therapy, so sort of direct, non-judgmental, patient-centered psychotherapy, engage the patient in treatment, discuss their maladaptive behaviors, explore the pros and cons of their use and balance them out. And then so sort of build on motivation for treatment and abstinence. So stepwise intermediate goals to reach the final goal of improved psychological, social, and occupational functioning. There's also strong evidence for CBT, probably first-line treatment at this point in time. So emphasize identification and management of thoughts, behaviors, and external triggers, promoting substance abstinence, develop coping skills, problem-solving skills, and replace those behaviors with healthier alternatives. So CBT always, seems to be the go-to when it comes to use disorders. Next slide. If treatment with CBT or MET is not effective after several weeks, then the combination of both is suggested, or the addition of contingency management. So contingency management is behavioral reinforcement techniques, typically a voucher incentive to encourage specific behaviors that promote treatment adherence or abstinence. And so contingency management is something that is gaining a lot of traction in the treatment world, both for opiate use disorder, but also for cannabis and for meth and for other things. There is some evidence for drug or addiction counseling. So this is sort of general or individual or group psychotherapies whose goal is to help patients reduce substance use by providing fact-based education regarding drug use and health risk. And then the mutual help groups, there is a Marijuana Anonymous, although I don't know of any in our community, and they follow the core 12-step principles of Alcoholics Anonymous to help support cessation or risk reduction. Next slide. So looking at the medication, again, none are FDA approved, so not trying to advocate for any off-label use. So you got dronabinol, so a synthetic delta-9, sort of a somewhat kind of replacement therapy. There's fairly weak evidence for this. Nabiximols, which is the plant-derived 1-to-1 ratio of THC to CBD. This has been used to treat MS. In studies have shown decreased overall usage, about a 50% reduction in use, and increased reported abstinence 23 versus 9%. So some evidence. CBD or cannabidiol, increased abstinence, less THC in the urine in the studies. Gabapentin. Gabapentin gets used for a lot of things off-label: reduce use, decrease withdrawal, improve cognitive tests. Some evidence for Ambien or nitrazepam, which is a benzodiazepine to help treat the sleep disturbance. Nitrazepam is not approved for use in the U.S. N-acetylcysteine, which is an antioxidant. It's an over-the-counter supplement, which was shown to have increased THC negative urine drug screens. So relatively safe alternative that you can get over the counter. Next slide. Topamax or topiramate. Sorry, I misspelled it. And it's an anti-epileptic or seizure medicine. So it has effects on the membrane ion channels and neurotransmitters. Has a relatively high dropout rate versus placebo, but did show a little bit less usage in the last week of the trial. Chantix, which is a tobacco cessation medication, again, decreased in days of cannabis use, but there's no established benefits for bupropion or Wellbutrin, fluoxetine or Prozac, venlafaxine or Effexor, Vibrate or Vilazodone, Strattera, atomoxetine, Depakote, lithium, Buspar, or Seroquel. So all of these have been tried and have not shown any benefit whatsoever, versus the other ones that had minimal, but at least a baby amount of benefit. Next slide. All right, so what is sort of the take-home points? Obviously not safe from pregnancy or breastfeeding. Hopefully can start to recognize some of the acute and chronic effects that we need to assess for all patients for cannabis use disorder. With increasing prevalence and concentration, there's trouble on the horizon related to cannabis and THC. There's significant psychiatric and systemic effects that we need to be aware of. And then CBT, MET, and contingency management all have some efficacy, although in limited evidence with medications. So that is the run through of cannabis use disorder. So any questions? My voice made it, so I'm happy about that.
Yes, thanks, Dr. Hanson. We appreciate that. Yes. Any questions, please unmute or raise your hand or use chat.
Dr. Hansen, this is Dr. Wonder Genus. I'm a pediatrician,
Yep.
and I have a question about adolescent use with THC. So as culture deems it more and more relevant and acceptable, I find that it's really hard to convince young adults and adolescents that there's no risk to cannabis use. Apart from motivational interviewing, in the primary care office, what can be done to kind of help these adolescents and young adults realize that despite what their peers are telling them, there is deleterious effects to this medication or drug, I should use to
Yeah.
say.
You know, I'll say, I guess, a couple different things. One of which you hit on, for me, personal opinion, Zach Hansen, the reason why I'm against medicinal marijuana and absolutely against recreational, I think the effect on our kids is the area that concerns me the most about it. So I could not agree more from that standpoint. I think with adolescents, it's the same struggle that you're going to have sort of across the board and helping them understand that they are not Superman or Superwoman, and that things that they do have consequences, whether that is jumping off cliffs or thrill seeking or whatever it may be. I think they're probably going to have a hard time of hearing it, but for me, looking at the increased risk of bipolar and depression and anxiety and increased psychosis and even development of schizophrenia, I know they're not going to necessarily want to hear the mental health effects of it, but I think it's significant. And it's very concerning, and then I do believe, in THC and marijuana as a gateway drug. And I, in the population that I see, a majority of the patients that I see, their substance use started with marijuana in adolescence. And I know that I don't see patients in my practice that smoke marijuana in adolescence and then quit, because they're not going to come in and tell me such things. And so I have a very skewed opinion and very biased sort of take on use, but I do feel like there is a certain level of sort of gateway to other things. And so I would try to, since you're probably not going to successfully convince them not to, I would probably really try to hone in on why they're doing it in the first place. And then if there's something there that you can treat, whether it is depression or anxiety or some other symptom, and try to find a more efficacious and sort of address the root problem. But if it's just sort of recreational and everyone else is doing it, it's an uphill battle, unfortunately.
I agree. With the screening, I know that there are several drug screening questionnaires out there that primary care docs can use. Most of them, though, are very vague when it talks about drug use. It doesn't specifically say marijuana. They've talked about adding vaping. Even that is kind of very vague. Do you know if there's anything coming out that's new and updated? Does anybody know that would give primary care docs a better handle on being more specific with the certain drugs that we should be screening for?
Not to my knowledge. I mean, I think if we were going to go from a generic, question, any mind or mood altering substances that you're using either with regularity or on rare occasions, and it leaves it broad. I mean, it could be alcohol, it could be tobacco, it could be marijuana, it could be meth, it could be anything, mind or mood altering, type thing, and you can even throw in that are considered over the counter, because, there are a lot of substances that are out there over the counter that are having a deleterious effect on our patients, kratom. Like, we weren't talking about kratom a couple of years ago, but now you see it on the storefronts, in bold letters. We've got kratom. I had a patient getting Finubut. Like, what's Finubut? It's some crap supplement that they get that's supposed to get them a little bit high. It's Delta 8. The list goes on and on of these sort of supplements that are out there that are supposedly safe that are sort of preying on this population, whether it be adolescents or adults.
Thank you.
Thanks.
Let's see, Dr. Baltier, you want to ask your questions? You also put a couple of things in the chat, so if you want to comment on those as well.
So as everybody, we've been dealing with a lot of cannabis use, and there is a cannabis abuse. It's called the Cannabis Abuse Screening Test, and it basically takes the DSM criteria, and that can be helpful. I think we're going to start using that because it makes them realize they can be addicted. I think there's this whole idea that you cannot get addicted behaviorally, and so we're seeing that a lot in our pregnant patients, and so I think that can be helpful. And then again, I agree, you can't really, make people quit, but making them aware of the health effects in terms of teenage brain and newborns, I think those are kind of what we're slowly targeting. But as patients realize that they can't reduce their use, they can't, they're having memory problems, all these other health consequences, that's really what we're targeting, and just being available to them is kind of been our point of it. But you're right, because this whole idea that you cannot get addicted to cannabis, where I didn't think you could, and over the last 5 years we've been seeing that.
Oh, yeah, they can, and the green movement is very powerful. They have a lot of lobbyists and a lot of misinformation that's out there that's sort of pushing their agenda. And it's hard for us to combat that because we're just old fuddy-duddies who just don't understand, or we're part of the pharmaceutical industry.
Any other questions for Dr. Hansen? All right, Dr. Hansen, thank you again. We really appreciate your time in doing that. Very informative.
Thank you.
And you're welcome. Yeah, and we will switch gears now and do the case discussion. And so you've already heard from Dr. Wonder Genius, but I'm going to pull up your case and you can just walk us through it. Ask any questions you have to the group. We'll have a discussion and we'll go from there. I'll give you one second. Okay, go ahead and take it away.
Excellent. Good afternoon, everybody. My name is Hillary Wonder Genius, and I'm a medical director at Anthem, the Unicare Medicaid MCO. I'm also a pediatrician, as Purely stated, but in addition to that, I also am an MAT provider. And so this case that I'm presenting is a young African-American lady who presented to me in February for an entrance into our MAT program. She had been to the emergency department the week prior to get some Suboxone and wanted to actually come into our program primarily for housing assistance. She has an abusive partner who is also her drug dealer, and this partner has been beating her up on and off, and she was tired of it and had been out in the street for several weeks, and at this point just wanted to find a safe place. So her primary reason for coming into our program was for stable housing, but at the same time, she did want to get clean. When we look back at her substance use history, she started using crack when she was about 17 years old, and then found that heroin was cheaper and easier to get a hold of. And so she started heroin about 3 years ago. Cocaine is her drug of choice though, and has been a heavy THC user probably from the time she was around a teen adolescent. Significant though, and why of what this case today is that she has she had a gastric bypass surgery in 2017 and has had significant issues with abdominal pain, particularly with eating after this surgery. And she finds that using THC every day is the only way she can settle her stomach and allow her to eat. She does drink socially on a regular basis, And when I asked her how much she drank, she literally said, oh, the airplane bottle size. And it has to be hard liquor, because why drink if you're not going to get a buzz off of it? And again, she stated that was because of her bypass surgery. She couldn't hold anything but small amounts of liquid and food in her stomach. Her children currently are in the custody of family members by court order, and it's unclear whether she is actively trying to get her children back. As stated earlier, she lives with her husband, who has been physically and verbally abusive to her. And intermittently, she leaves him to be on the street when it's too much to handle. She will go back to him, though, after a few weeks, because he usually provides her the drugs that she needs. And she also finds that she has safety in his house as far as being off the street. However, this partner, again, not only is physically violent with her, but also doesn't allow her to attend important appointments. So she has missed court hearings related to the custody of her children. She has missed doctor's appointments with follow-up to her GI issues, a whole host of things that I'm not quite sure if she is truly taking responsibility for some of these missed appointments, but she certainly seemed to blame most of them on him not allowing her to leave the house and attend these appointments. So she gives a good talk, but she doesn't always seem to follow through. And I suspect that she's still using both the crack, the heroin, and the THC. Several times during our group meetings, she's been noted to be nodding off and reminding that she needs to stay alert during these visual group meetings that we're having online. She had a recent COVID exposure, so she has been unable to come into this for witnessed urine drug screens. She's also very averse to working with the peer recovery specialist, stating that she has no interest in any 12-step programs. But she will often fall back on her quote unquote faith as a support mechanism for her. But again, that depends on who she's talking to, because some staff she'll say that faith is very important, and other staff she'll say faith has no relevance to her at all. We have noted that she tries to triangulate with the staff to get what she wants. And what she really wanted was stable housing. And so our program had actually put her up in a hotel for a couple of weeks. But when she was asked to follow through with court documents verifying her children's custody case, she was unable to follow through with those. Ultimately, she had to leave the housing that our program had temporarily provided for her, and now was relying on friends to house her in a hotel for a few days. So this was written about 2 weeks ago. And since that time, we have lost contact with her. And she has not shown up for any more IOP programs or any MAT group programs. So just going back to her comorbidities, she had the gastric bypass in 2017. Her highest weight was 390 pounds. And on the date of her screening, she was weighing 135 pounds. I asked her why that was such a huge drop in weight. And she said, yeah, the doctors had expected me to come down to about 270 pounds, but I just don't eat now. She does have peptic ulcer disease, for which she takes several GI cocktails. And her psychiatric history includes depression, anxiety, and PTSD. There's a question about a dissociative personality disorder that came up during our evaluation, where she spoke about a different person that would go and get high, and that she would not remember anything from when she was high. That was different from the person who was taking care of her kids. So it wasn't quite clear if there was really a true dissociative personality disorder, or that was just a good way for her to say, I don't remember when I'm high. She has had suicide attempts in the past. Back in 2018, she overdosed with some pills. She spent 4 days in the ICU, woke up and was discharged without any follow-up. as directed by the hospitalist. So she was not admitted to a psychiatric unit for suicidal ideations, nor did she follow up with any outpatient behavioral health provider back in 2018. So on exam, she is, and this is the exam back in February, it was a telehealth exam. So she appeared well-nourished. She was not emaciated. She was alert and oriented, and her mini mental exam appeared normal to me. She did not have any suicidal ideations, nor did she seem delusional at the time of the evaluation. However, I felt that her words were well rehearsed, deliberately spoken. She clearly knew what she wanted to say and knew what to say to get what she wanted. Her COWS done by the on-site nurse was recorded as an 8, and her urine drug screen at the time was positive for cocaine, opiates, which included fentanyl, morphine, oxycodone, THC, and buprenorphine. And listed there are her medications. So my question to the group is, this young lady really feels that she cannot get through her pain without her THC. I had actually increased her Suboxone dose to 20 milligrams a day, which helped with her cravings. It has not really impacted her THC use. And wondering if there is a place for medical marijuana use in this situation. And just in general, for those of you who are actively in MAT, as MAT providers, how do you manage THC use with your MAT patients when they just don't seem able to abstain or even harm reduce with the THC? That's my presentation. Any questions or any answers?
I have a question about when you increased her buprenorphine, did she report any impact on her pain, and is she taking it? How is she taking the buprenorphine?
So she is taking the sublingual films, and I had increased her buprenorphine from 16 to 20, primarily because she was having intense cravings that were not resolving, and she would go out on the weekends and still be using the heroin on the weekends. And so that was why I increased her buprenorphine to 16 milligrams, 16 and 4, in hopes of getting at least the cravings for the opiates under control. I knew that probably was not going to do a whole lot for her THC. So I guess my point in this presentation is to ask, is the THC something I have to live with if she ever comes back? Or do I kind of stand my ground and say, listen, you really need to work on abstaining from this THC and let's get you back in with GI, which I did recommend to her to get your peptic ulcer disease under control.
Go ahead, Dr. Baltier, you have your hand raised.
Yeah, so Dr. Wonder Genius, how is she doing with her buprenorphine? Because I mean, she's really got a opiate addiction, she's got a stimulant addiction, and she probably has THC addiction.
Mm-hmm.
So I would wonder, how is the buprenorphine helping with her heroin addiction and keeping her in treatment?
Unfortunately, ever since she lost the housing that we have provided her, she has stopped coming back to, I've lost contact with her in the last 2 weeks.
Yeah, because the way I would approach her is the THC, although that's what our main talk is today, would be the least of my concerns at this point, honestly, just keeping her in treatment. She's probably not ready to approach getting her children. I think that's probably off the table at this point for her, but finding out, with her trauma and housing, those are her primary. And then, we've had women, I haven't dealt with their THC till they're in a better place. And so, and so we just kind of try that later. I don't know how much because we haven't had any impact. I think her danger to her life, as you know, is probably her heroin and then her cocaine addiction and getting her life together. So
I agree 100%. And I guess I brought this up not to say that I'm kicking her out of the MAT program because she's still on THC, but rather to try and discuss with the other team members who are not physicians. You know, they have a hard and strict rule. You got to be off the THC within a month. And I'm like, first of all, I don't think that's going to work for this lady. And, but just wondering, is there ever any, I guess in this case, you could call it medical marijuana. In her mind, it is at least, that's why she's using. And would it be inappropriate for me to say, hey, go find a medical marijuana provider to at least get your drugs legally? Is that an inappropriate approach?
I think from my side, that's a personal, professional kind of judgment. I haven't made that because I think, as Dr. Hansen said, I prefer the term medicinal marijuana. I really have a hard time with it being medical. And just on my personal point, I don't think criminalizing it helps, but so that's a whole other side of it, whether it's criminal, legal, or illegal, that's a whole, but I don't find that I could in good conscience prescribe it. And actually here in West Virginia, you're not even prescribing, you're just diagnosing that they either have PTSD, chronic pain, certain conditions. And so I think, what we've done is had I hate to say permissive attitude, but dealt with the higher level problems first, which is housing, abuse and opiate and stimulant addiction. And then build that trust, and hopefully she gets to a better place. Because not saying that the marijuana is okay, but it's I think just the least of it. I would just continue her in treatment and try to get her other issues under control. And I agree with you, but I personally wouldn't go down the medical marijuana route, because then it confuses my other we do groups and then they're like, oh, well, what about me? I've got this, I've got that. And then before I know it, we are really down that path. And I've chosen not to go that because I still don't see the evidence supporting that. And I probably had a more permissive attitude toward cannabis 5 years ago than I do now. I've just seen the damage it can do in people that have addiction. So that's kind of been my in our group's decision. So I'm sure some of the other people doing this have some other comments on that.
Thank you.
Yeah, I'd like to kind of emphasize what others are saying, because of the context where she's kind of involved with CPS. It'd be important to keep in mind that even if it were considered medicinally allowed, that a judge in her case could still determine that because she's using marijuana, she's using an intoxicating substance, and that they can still make those decisions. So I think when she is stable, to kind of have that conversation with her, that there are other risks that maybe she's not thinking about, but it does sound like some higher level things like basic housing and making sure she's medically stable are going to take precedence.
Thank you. Unfortunately, like I said, we've lost contact with her, but a lot of times it's a revolving door and she may come back in 2 or 3 months.
And you had asked also, this is a great case, by the way, you had asked also about what do other programs do? Some in our program in Morgantown, we actually have a group specifically for folks who are struggling to discontinue marijuana, but have discontinued everything else. For people who are struggling with multiple substances, we kind of intensify their treatment. But if it's marijuana only, we actually have a group specifically for those folks and do a lot of education around the stuff that Dr. Hansen presented today around the negative impacts of marijuana on the brain, on the body, on mental health disorders, and also strategizing around discontinuing use, especially because the landscape of accessibility of marijuana and acceptability of marijuana is really changing in the state.
Awesome. Thank you, Dr. Lander.
Any other questions or comments? It's been good. Tanya, I saw you unmute and then mute request. So, okay, just making sure. Just making sure. Dr. Hanson.
I mean, I'll just sort of throw out, I mean, one of the discussions that we've had here at Proactive Huntington for quite some time, you know, is whether to consider someone who's regular consumer of marijuana, whether they are able to sort of phase up into the biweekly or monthly groups. Been an interesting debate. We've had some that say absolutely not, and we have some that have said, you know, that it is what it is. If they're not going to change, then, you know, you can't see them weekly for 5 years necessarily, if all things are considered. But you know, in a perfect world, you know, they would all stop. But I mean, generally speaking, I mean, we allow patients to phase up even if they're continuing to use marijuana in our program, just for fear of not wanting to keep them at a level of care that is not appropriate if they're otherwise abstinent from all other drugs of abuse.
All right, we have 2 minutes left. Dr. Baltier, you can have the last comment here. To raise your hand. You are on mute.
I think he
I
put
wouldn't-
something in the chat.
Yeah.
Oh,
Yeah,
okay.
I wouldn't give up on people quitting marijuana. We've had people weekly for 4 years, and we just started a marijuana group. And as an incentive not to join the marijuana group, they're quitting. And one of them's getting her master's degree. So don't, you know, weekly they get tired of us. And so again, I'm fairly permissive, people know, but I think it when it's affecting their lives, it affects them. So I wouldn't give up.
Oh, that's awesome. That's awesome. This young lady does see her children
Good.
because they're with family.
Good. All right. Well, thank you for the case presentation. Dr. Wonder Genius is very good. Really relevant, obviously, to today's talk. So thank you again to Dr. Hanson. We will be meeting again in April, on April 11th. So be on the lookout for the reminder there. We're going to be talking about labor and delivery with PPW with SUD. That's going to be Kelly Lemon. It's going to be presenting on that. So we look forward to that. And if you have a case around that topic or something else, please feel free to submit using that link in the recap email. So thanks again, everyone, and we will see you in a month.
Hey, can we talk about Kratom next time too?
Sure. Put it on the list.
Thank you,
All right.
everybody.
Yeah,
Thanks,
right.
everybody.